Hey everybody, we've got another heart today. This is number 1512 in our collection, and we'll do a quick teaser or preview of the main phenotypic features first. And just externally looking at this heart, you can tell that this heart has undergone extensive surgical repair. There's an RV to PA conduit here. There's suture line in the ascending aorta here. There also appears to be a Damus-Kaye-Stansel where the native pulmonary trunk has been anastomosed to the ascending aorta, or in this case, a left ventricle to ascending aorta conduit here. And obviously there is evidence of a right atriotomy as well, which makes it seem like this probably is a heart that has double outlet right ventricle. So we'll start off by going to the right ventricle. We can tell that this ventricle is a morphologic right ventricle because it has coarse trabeculations. There is a septomarginal trabeculation. And here we can see that in fact there is a large baffle here, which is baffle closing an interventricular communication, consistent with a heart with double outlet right ventricle, and an interventricular communication living within the Y of the septal band, which means between the cranial and the caudal limbs of the septomarginal trabeculation. And then here is this RV to PA conduit here. And then if we go to the left ventricle, here we see where the interventricular communication was. And once again, we see this baffle closure of a interventricular communication that was likely an outlet intraventricular communication. And you can see this kind of ledge here, which implies that this was a double outlet right ventricle with aortic override of the right ventricle. But now let's go ahead and look at this heart in more detail. The heart would have sat roughly in the chest like this, anterior surface towards the screen, posterior surface towards the turntable, left over here, right over here, head or superior up here, legs or inferior down here. So as always, why don't we go ahead and try to find what externally appears to be the right atrial appendage. And here we have an appendage that's triangular, broad-based or pyramidal in shape, consistent with the morphologic right atrial appendage. Here we see what appears to be the superior caval vein draining down into the roof of this morphologic right atrium, at least what we think it is so far. And we see a catheter that's coursing through the superior caval vein. But let's go ahead and open up what we think is the morphologic right atrial appendage. And when we do that, we do see pectinate muscles that spill outside the confines of the appendage, consistent with a morphologic right atrium. We also see the superior caval vein here opening up into the roof of the right atrium. We once again see this catheter that's coursing through the superior caval vein, through the right atrium, through the tricuspid valve, through the right ventricle, and out the RV to PA conduit. But when we look at this right atrium, we do see what appears to be the remnants of an intraatrial communication here that was primarily closed. You can see the suture line right back here. And then when we look further back in this heart, I'm sorry if it's not easy to see, but back here is the mouth of the coronary sinus, and you can see the Thebesian valve here guarding the mouth of the coronary sinus, okay? So here's the mouth of the coronary sinus, here's the Thebesian valve guarding it, and then here is the tendon of Totaro. So the mouth of the coronary sinus, the tendon of Totaro, and the right-sided atrioventricular junction form what's the triangle of Koch, and at the apex of this triangle is where we expect to find the atrioventricular or AV node. When we get to the right-sided atrioventricular junction here, we find that there is an atrioventricular valve that appears to have 3 leaflets, 1, 2, 3. There are direct septal connections of this valve, consistent with a morphologic tricuspid valve. So this would be the anterosuperior leaflet, this is the septal leaflet, and this is the inferior leaflet of the tricuspid valve. This valve leads into a ventricle that has coarse trabeculations, has a septomarginal trabeculation, all consistent with a morphologic right ventricle. And once again, we see this catheter that's coursing from the superior caval vein to the right atrium, through the tricuspid valve, through the right ventricle. Here we can see the margins of an interventricular communication. This was likely between the limbs of the septomarginal trabeculation, the cranial and the caudal limb, aka the Y of the septal band, making this an outlet type interventricular communication. And you can see this baffle closure of the interventricular communication, as is frequently noted in double outlet right ventricle. Here is a right ventricle to pulmonary artery conduit, and you can see the actual outflow tract here. And once again, you can see this catheter that goes through the RV to PA conduit and then exits it. Here's the distal portion of the RV to PA conduit that then anastomosis to the branch pulmonary arteries. Now let's take a look at the posterior aspect of this heart. And here is the left atrial appendage. You can see this is finger-like and tubular. So we'll go ahead and open the heart here. Here we find a smooth-walled atrium consistent with a morphologic left atrium. Here is the left atrial appendage here. So here is the orifice of the left atrial appendage. And you can see all the pectinate muscles are confined within the appendage itself, consistent with the morphologic left atrium. Once again, a smooth atrial vestibule here. And then we can see some of the pulmonary veins draining back to the left atrium. Now, when we look at this left atrioventricular junction here, we find that it's guarded by an atrioventricular valve that has two leaflets, 1, 2. This valve does not have any direct connections to the ventricular septum, consistent with a morphologic mitral valve. So here's the anterior leaflet of the mitral valve. Here's the posterior leaflet of the mitral valve. We can take a look at it from here as well. So now we are looking at what is the morphologic left ventricle. And here is the anterior leaflet of the mitral valve. We start seeing the left ventricular outflow tract here. And we can see this material used to baffle close or tunnel close this intraventricular communication. And you can see this ledge here that's produced by the override of the left ventricular outflow tract over the morphologic right ventricle. Here is the actual left ventricular outflow tract externally, and I can put our probe through here as well. And you should see our probe advance through. It's a little difficult, but you can see that there was a left ventricular to ascending aorta conduit that was placed here. And here is what was the native pulmonary trunk. And these two have been anastomosed together in a Damus-Kaye-Stansel anastomosis. And then the entirety of this DKS anastomosis sits onto the left ventricular aspect of the now closed interventricular communication, such that this is now the neo-aorta, both the native pulmonary trunk and this conduit. And this RV to PA conduit is the sole egress for blood from the right ventricle. So here's the ascending aorta, here's the transverse arch, and then of course, here's the descending aorta here. And here is the ligament of the arterial duct. Let's see if it's still patent for some reason, and it is not. So here is the ligament of the arterial duct. Here's the distal aspect of the RV to PA conduit, the proximal aspect of it. Here's the DKS anastomosis consisting of the native pulmonary trunk and a LV to aorta conduit. And so we have a heart with double outlet right ventricle that underwent a DKS and then finally a RV to PA conduit placement with an interventricular defect closure I can't tell you if the repair was staged. It seems most likely that it was, with the DKS occurring first, followed by the RV to PA conduit placement and the intraventricular communication placement later, but I haven't looked at the historical records for this specimen, admittedly. But an interesting heart with an interesting repair.